Dear colleagues, dear friends, it is our great pleasure to present already the 40th case in the ASAS Case Library. Today, we're dealing with a case of a 54-year-old female patient who was referred to a rheumatologist because of chronic back pain with onset about 5 years ago. Already here, you can ask why this patient was referred to a rheumatologist. Not very typical for spondyloarthritis, age of onset, but if you look into back pain characteristics, you will understand why the patient was referred. You see that the patient started having this back pain rather slowly with morning stiffness, predominantly in the lower lumbar region, for more than 30 minutes, with improvement of back pain and stiffness with exercises and not with rest. Also pain in the night with awakening, and also alternating buttock pain. So you see the full spectrum of signs of so-called inflammatory back pain. And of course, we educated our referring physicians to pay attention to inflammatory back pain and then to refer patients with inflammatory back pain to us. It is important to mention, of course, that inflammatory back pain doesn't mean automatically that there is inflammation behind these symptoms. But it is still a very good screening parameter. So we want to see in our practices, in our rheumatology practices, patients with inflammatory back pain, because in this patient population, the probability of axial spondyloarthritis is relatively high. You see also that there was a positive response to NSAIDs with substantial reduction of pain. There were no clear peripheral manifestations at the current presentation. There was some suspicious history, suspicious of peripheral NSAIDs. No extramusculoskeletal manifestations, no family history. In terms of mechanical stressing factors, there is some physical demand at work, no regular sporting activities, and no history of pregnancies. At the current clinical examination, there were no clear signs suggestive of spondyloarthritis or other condition explaining back pain, with some limitation of the lumbar spinal mobility due to pain, no peripheral, no extramusculoskeletal manifestations, and BMI, as you see, was corresponding to a slight overweight. In the lab, HLA-B27 was negative, CRP was just at the upper level of the norm, and there were no abnormalities otherwise. The patient brought some images, historical images. The first set of images was done about 2 years ago, and it was only an MRI of the lumbar spine. And let's have a look at lumbar MRI first. So that was a period of quite intense back pain, and what we have here is a stir sequence with bright signal from water and a dark signal from fat tissue. So we're looking for active inflammatory changes, and we're always looking also at condition of intervertebral discs, because they can help us to differentiate between truly inflammatory and non-inflammatory changes we might see in vertebral bodies. So here we do not see in lumbar spine, at least at this view, no major changes. So slight signs of degeneration of the discs. You see a loss or decrease of intensity of the water signal, but nothing really remarkable. But when we go to the lateral portion of the spine, then suddenly we start seeing a lot of edema, a lot of water signal corresponding to bone marrow edema. And this is, so you see that this side is normal, and only on this side, the left side, I guess, we see inflammation in the lateral structures, and we see also bone marrow edema in the sacrum. And this view, it is difficult to say what is the origin of this. This might be related to facet joint arthritis, might be also manifestation of mechanical problem, and this is either a continuation of bone marrow edema to the sacrum, or maybe it is something that coming from sacroiliac joints. So we will see what is happening there in the following images. We have also T1 weighted sequence here, where we don't see any major structural changes compatible with spondyloarthritis. We see this dark signal as discussed already. And this is also a situation where axial planes might be very helpful in terms of differentiation, what is going on there. So here we have only two weighted sequence. You see that fat and water signal are bright, hyper intense, and now I'm trying to come to the area which was affected by this bone marrow edema on sagittal stir view, and here we are. So we are here at the level of the probably affected facet joint, and you see the difference. You see the difference in the shape, you see the difference in the size between two facet joints, and you see that there is an effusion. There is a bright signal in the left facet joint, and you see also this signal hyper intensity in the sacrum, most likely corresponding to bone marrow edema we observed before. So already here you might have an idea that this might be more likely related to a mechanical issue, but inflammatory problem is not yet completely excluded. So patient was doing okay for some time, treated by an orthopedist, and then came back in approximately 2 years with increase of back pain, and at this time point, imaging of the spine, and also a few months later of sacroiliac joints was performed because of these inflammatory characteristics. And I would like to invite Professor Hermann to demonstrate those images and to give his perspective on what is happening in this case.
Well, then 2 years later, the next MRI of the lumbar spine was performed. You see the exact same protocol was applied, consisting of a stir sequence, a T1 weighted sequence, and also a T2 weighted sequence in the axial plane. Looking at the stir sequence, we see that there is some minor bulging of the disc here between the L3 and 4 vertebral bodies. So we can quickly compare with the first presentation if that was a relevant finding already at that time, or if that did develop. And I think there is no much change here in between. So we can be, we do not need to consider this as a major finding. Also, when we go to the left side on the lateral edge, we see again there is some bone marrow edema in the osseous structures to the lateral side, but it is way less intense as compared to the first time. Again, we will compare that side by side. We had this very intense bone marrow edema here, and now we see that this is much lower of signal intensity, and it also seems to be changed in the shape of the bones. As you see, there were some pedicles to be seen here with the joint cleft in between, or maybe that's the fluid in the joint. And now it is really hard to distinguish, and it's recommendable to have a look at the axial images. So here we see the axial images again, starting more or less in the third vertebral body, going down to our segment where the findings are. That's the segment between the fifth lumbar vertebral body and the sacral bone. And you can see that we have here now very large osteophytes originating from the pedicles. The joint space of the facet joint is no longer visible. If you compare it with the baseline image, you can see there's this fluid here in the joint that is now gone. So we do not see any fluid in the joint. So we can assume even that the cartilage of the joint is gone, and this joint is no longer able to make slight movements and to support the lumbar spine in its movement. So it's decreasing the possibility to move of the patient due to this blocking here. Also, it was shown that we had this fluid in the joint. There might have even been a cyst originating from the joint, and it might be that we had a slight listhesis at the baseline. That's maybe only 1 or 2 millimeters, so that's not relevant. But we can maybe assume, due to the fluid in the joint, that there is some instability in this segment, and this might have been even more. Now, as we can see that if you measure it exactly, maybe it's now 3 to 4 millimeters, and before it were only 1 to 2. So this is really something that slowly evolves, but I'm not sure whether this is still an unstable segment, because we now have this bulgy osteophytes over here. So no MRI examination is complete for the rheumatologist if there's no image of the sacroiliac joints. So these MRI scans were performed after the consultation, and we can see that this is a oblique coronal scan of the sacroiliac joint. We see the anterior contour of the joint. We see the middle contour of the joint, and we have here the posterior aspect. And if you look carefully, I think you have already seen it, there is this bone edema in the sacrum on both sides, and it is confined to the anterior edge of the bone. There might be some sclerosis over here, and that can be appreciated again in these oblique axial slices, where we see the bone marrow edema here in the anterior aspect of the sacral bone. And going also to our facet joints, we see that here we have some edema in the facet joint still on the left side, especially in this slide. There's some bone edema, but we have also some soft tissue edema behind the joint. Also maybe a little bit of residual edema in the sacral bone. And on the other side, we now have also some capsular soft tissue edema. So in total, and also bone edema, as I see bone edema here in the facet, in the articulating facet. So in total, we have quite interesting pattern. We have osteitis condensans pattern clearly. That might be due to the slight increased body mass index, and also the mechanical demanding job. And we have this osteoarthritis of the facet joint that is leading to a decreased possibility to move the spine, and this might also lead to problems and clinical symptoms. So Dennis, what would be the treatment, and how would be the global interpretation of these changes?
Thank you very much, Kai. I think in this case, it is very likely that the issue is related to rather unspecific mechanical issues in the lumbar spine. So the treatment would be, first of all, conservative, will consist of symptom-related intake of NSAIDs and physiotherapy with exercises aimed at strengthening the muscles in the affected area. Otherwise, this case is also interesting from the diagnostic point of view, because you see some bone marrow edema also in the sacroiliac joints. And in this case, spondyloarthritis, based also on a clinical profile and alternative explanation of back pain, is rather unlikely, But imagine you have a similar bone marrow edema to sacroiliac joints in a young male patient who is B27 positive. And here you see a limitation of the conventional protocol of MRI of sacroiliac joints that doesn't incorporate erosion-sensitive sequence. With just STIR and T1, it is sometimes challenging really to prove that there are no erosive changes. So we strongly recommend for the diagnostic cases to have also erosion-sensitive sequence in. Otherwise, there are a few other take-home messages from this case. First, as often discussed in the past, inflammatory back pain doesn't mean inflammation behind this pain. So in this case, there was bone marrow edema induced mechanically, causing most likely inflammatory back pain, and at the end of the day, it was a mechanical issue. And another important point, we have here mechanical problem in the typical area, so in the lumbar sacral transitional area. Most frequently, we see an osteochondrosis with degenerated disc disease L5S1, but in this case, the disc condition was rather normal, and the key was to have a look not only in the middle of vertebral bodies, not only at the intervertebral disc, but also into posterior structures. So sometimes they are a source of pain in patients coming to us.
Also, I think what can only be stressed is, and you mentioned it in the initial presentation, that the slices need to be taken into account to the very lateral edge, and sometimes only the protocol allows to visualize just the vertebral body without the area outside of it. So it would be recommendable to have at least two slices outside of the vertebral body to each side. That means 4 slices more than we would need. And this, of course, increases scanning time a little bit, but I think it's worthwhile, as we could detect nicely the facet joint problems here, and also found a glimpse of edema in the sacral bone that might have been related to the osteitis condensans. A better way would also have been to scan it in a coronal plane. So a lot of institutions are used to have 2 sequences in the sagittal plane and then a third one in the coronal plane, usually a STIR sequence. And that is quite useful to see if there are some scoliosis, but also we see nicely the sacroiliac joints if these slices are going far enough into the joint, and they give some overview, but they can, of course, not substitute a proper protocol of the sacroiliac joint MRI.
Very good. Thank you very much, Kai. Thank you all for listening and watching, and see you next time.
See you at the next case. Bye-bye.